Good evening and welcome. I'm Martha Raymond, CEO of the GI Cancers Alliance, and I'm joined by our partners from Debbie's Dream Foundation, Curing Stomach Cancer, Gastric Cancer Foundation, Hope for Stomach Cancer, My Gut Feeling, Stomach Cancer Foundation of Canada, No Stomach for Cancer, and Stomach Cancer UK. Together, we are pleased to share the latest findings from ASCO 2026. On behalf of all our partner organizations, thank you for joining us. A few brief housekeeping notes. Please submit any questions through the Q&A function. Our expert panel cannot address personal medical questions, so please direct those to your own healthcare provider. The chat function is disabled for this webinar. Please mute your microphone for the duration of the webinar. And before we begin our real-time poll, I'd like to thank our outreach and logistics team, Jen Higgins-Spires, Danielle Ripley-Burgess, Aki Smith, Teresa Tiano, Keith Kaplan, and Margaret Ann Simonetta. And now we'll launch a brief 5-question poll. We'll pause for about 30 to 60 seconds, and then we'll share the results in real time. We have about 15 seconds left, so if you could finish up, that would be great. And do we have our results yet, or will we come back to those toward the end of the webinar? Wonderful. Well, thank you, everybody, for completing the poll, and it gives us insights into not only this webinar, but future webinars that we will be doing in partnership so that we can bring you the information that is most important to you. And now it's my pleasure to welcome Jen Higgins-Spires, who will introduce our speakers. Thank you.
Hi, everyone. I'm honored to introduce 4 leaders whose work and efforts shape the future of stomach cancer care. Dr. Sam Klempner, gastroenterologist from Massachusetts General Hospital, Dr. Yelena Janjigian from Memorial Sloan Kettering Cancer Center. Although she is not able to join us live today, she did provide a recorded ASCO update that we'll be sharing. Dr. Elena Elimova is from Princess Margaret Cancer Center, and we have Frank Blandon, a patient advocate and a stage 4 stomach cancer patient, sharing the lived experience, what grounds all of this work in real-world impact. So now we'll watch Dr. Janjigian's video.
Hello, good to see everyone. I'm Dr. Yelena Janjigian from Memorial Sloan Kettering Cancer Center in New York. Apologies for missing the meeting and not being able to be there in person, but it's a great opportunity for all to learn about the updates and ASCO of 2026 and advances in gastric and esophageal adenocarcinoma. Of course, the excitement in HER2-targeted therapies continues. We saw data from zanidatamab that continues to impress us with subgroup analyses and safety data from the Horizon gastroesophageal adenocarcinoma. And hopefully Zani will be available to our patients in the near future. We saw data with the subgroup analysis, and we're seeing again the trend to show that the benefit is in with combination of zanidatamab chemotherapy and anti-PD-1, progression-free and overall survival versus chemotherapy and anti-HER2 therapy, irrespective of PD-1 status, so PD-1 positive or negative patients. And so the comparator arm, of course, did not include immunotherapy. It was chemo and trastuzumab comparator, but the safety and updates focus on diarrhea, which was managed with prophylaxis, use of anti-diarrheal agent and loperamide. The field is constantly evolving. It's important to have all options for our patients, but of course, zanidatamab and anti-PD-1 therapy together appear to have benefit for this patient population. We also saw newer drugs and more targeted therapies for MET-amplified tumors. We saw interesting data with a combination with a drug called savolitinib, which showed tumor responses in approximately 1 in 3 patients, and this paves the way possibly for the future studies. A lot of the drugs and the excitement is coming out of Asia. There were major breakthroughs, of course, in those patient populations. I think probably the number one question I guess asked, what about RAS alterations, KRAS amplifications and mutations, of course, occur in our gastric cancer population. And the plenary data with KRAS inhibition was very moving, and everybody was excited to see. And we are doing some studies in that population, but the Revolution Medicine compound is not available in our clinic right now. So more perioperative treatments are again right now front and center. Astrum 006, the PD-1 plus doublet chemotherapy was a positive study showing that improvement, particularly in PD-L1 positive patients, is good to know. So again, confirmatory data for our patients who are potentially not a good candidate for FLOT, or may want to discontinue one of the components of FLOT therapy and can continue doublet such as FOLFOX or flow-like regimen with anti-PD-1. The Matterhorn treatment options are still very preferred in patients who are fit, and we continue to show event-free survival and benefit by subgroup analysis. And all treatment periods, you could discontinue some periods of some components of FLOT and continue whatever therapy you're able to tolerate. It does not appear to impair the efficacy. And of course, we are seeing increasing evidence that combination therapies may be a utility, especially the drugs we saw in plenary session, cadonilimab, which is a dual PD-1 CTLA-4 bispecific, meaning one antibody targeting both immune checkpoint blockade options. And this was a great study from lung cancer patient population with cadonilimab. However, our Attraction 06 study from Korea and Japan did not improve outcomes so far for combination of nivolumab and ipilimumab with CTLA-4. So not prime time yet for our patients to use those drugs in first-line setting with chemotherapy. We are doing a trial with cadonilimab, which is the newer, safer anti-PD-1 CTLA-4 bispecific, which means that those are important molecules being targeted at the same time. And we actually have the follow-up study to Matterhorn, which is a FLOT plus cadonilimab study in early stage gastroesophageal cancer patients. So if you have a patient or interested in the study, feel free to reach out to me. So it's exciting, of course, to see more and more drugs entering the clinic. Continue to follow us for research updates and have a great day. Thank you.
All right, really nice overview from Yelena, as usual. Talking a little bit about sort of some of the key areas from ASCO. We've got about 45 minutes to dig into some of this. Please feel free to put questions in the chat, Could be anything. I saw most of the people are interested in biomarkers and precision medicine and new treatments, so we'll try to focus on that. Also, about two-thirds of you all are under the age of 60, which I think is highlighting a problem that a lot of the advocacy groups touch on, which is younger patients, earlier diagnoses. It's something that we're seeing as epidemiologic trends. But before we get into it, I'm Sam Klempner. I'm a GI Med Onc at Mass General in Boston, and I'll let everyone else introduce themselves, but I'll hand it off to Elena.
Thank you, Sam. I'm Elena Elimova. I'm a GI medical oncologist at the Princess Margaret Cancer Center in Toronto, Canada. And I'll pass it on to Frank.
Hi, I'm Frank Blandon. I'm a stage 4 stomach cancer patient, and I'm a patient advocate. I've been on treatment for about a bit over 2 years now.
That is awesome to hear. We wish we could get many, many more patients, and some of the trials that Elena has done is pushing the survival into the 2-year mark. So maybe we'll just start there, since HER2 is something that everyone on this call knows is super important to know about yourself. If you get diagnosed with gastric cancer and someone asks you about your tumor, you should be able to give the answer of your own HER2 status. But maybe give like the 10,000-foot view, Elena, about, HER2, how we got here, and then maybe sort of lay summary of Zani, since you are the lead author.
Thanks, Sam. So I think, our first breakthrough was now, I think, over a decade ago, right? TOGA. It was Herceptin and chemo versus chemo alone. And we did see that the addition of Herceptin to chemotherapy in HER2 positive patients, which is of course defined as patients that are IHC 3+ or IHC 2+ FISH amplified, improved survival. After that, our next kind of big breakthrough was the KEYNOTE-811 regimen. And that came from the fact that we knew that the addition of anti-PD-1 helped patients in the HER2 negative setting. So, we added pembrolizumab to chemotherapy and Herceptin. I'm sorry. What we found there is that in PD-L1 positive patients, they benefited from the addition of pembrolizumab. Unfortunately, patients who are PD-L1 negative did not seem to benefit. And we did push the survival forward with the addition of IO. Now, what was different about the Horizon GA study was that we looked at a novel HER2-targeted therapy, which is a bispecific therapy. And you've heard Yelena talk about bispecific. We think that the mechanism by which bispecifics work is a little bit different. Perhaps they in themselves promote how our immune system works. So zanidatamab was added to tislelizumab, which is another PD-1, and chemotherapy. At the time that the study started, our comparator arm was chemotherapy and trastuzumab. But we knew that perhaps the standard of care was going to change with KEYNOTE-811, and that's why there was this third arm with zanidatamab, IO plus chemotherapy. And the results of this study were originally presented at GI ASCO. And what was really exciting about the study was that we saw an improvement in overall survival with the addition of zanidatamab and PD-1 that was actually greater than 7 months. And I think Sam and I can both speak to the fact that we rarely see 7-month improvements in overall survival. And that's what everyone was excited about. I think the second part that was really important, and I think surprised all of us, and this was the update from ASCO this year, is that we particularly looked at PD-L1 positive and PD-L1 negative patients, because in KEYNOTE-811, the PD-L1 negative patients didn't seem to benefit from the addition of IO. However, when zanidatamab is added to IO plus chemotherapy, both PD-L1 positive and negative patients benefit. So I think this opens up this treatment option for actually all comers. So that is what's new, and I think that's what's exciting. And now we're trying to figure out what exactly makes the drug work in that way.
I want to ask you a practical question, and then I'm going to come to you, Frank, for sort of the patient experience about, being on therapy for a long time. Elena, you've had probably the most, if not one of the most hands-on experience with this drug in the world since the phase 1 and 2 studies. How long have you had people on? Do you see any long-term concerns? Does the tox kind of fade over time? We'll get into the toxicity a little bit later.
Yeah. So I think what was really interesting, as you said, I have had patients that were a part of the phase 1 study, the phase 2 study. I have patients from the phase 1 study who are survivors for over 5 years now. From the phase 2 study, I have a patient who stopped all treatment with no evidence of disease. And from the phase 3 study, so yes, to answer your question, Sam, we do have long-term survivors. But I think following this drug long-term on the phase 3 study will be extremely important, as it is important in all of our studies. I think in terms of the toxicity, the diarrhea primarily happens at cycle 1. It was predominantly actually occurring once we started using FOLFOX or CAPOX-based chemotherapy. So when we used it just with paclitaxel or capecitabine, we didn't actually see a lot of diarrhea. What I will say that after you stop chemotherapy backbone, or if you just give 5-FU alone, the diarrhea is really not an issue. And generally, what we do is we dose reduce 5-FU or capecitabine doses, and then the diarrhea again becomes not a major issue. And that was also presented at ASCO this year as a poster. I generally would stop platinum, and I think most medical oncologists in the US probably do similarly after 4 to a maximum of 6 months. I find that sometimes I will continue 5-FU or capecitabine long term, not in all patients, but I do continue anti-PD-1 and HER2-targeted therapy indefinitely, unless the patient asks me to stop, as my patient did in this case that I mentioned to you, the long-term survivor with no evidence of disease. So I think that would be my practice. What do you do, Sam, usually?
Yeah, I'm gonna come to Frank and then I'll give you my own answer. So Frank, you said you've been on therapy 2 years. If you're willing to share what that is, feel free. If not, don't worry. But maybe the question is, how do you psychologically feel about, coming off of therapy, continuing therapy? Are there things that you think about when making this decision?
Yeah, so I've been on. I started with FOLFOX and on immunotherapy a bit over almost 2 years. Well, a little bit over 2 years actually. Um, and as she mentioned, I did about 6 months of oxaliplatin, and then that would stop. And then I was on 5-FU for a couple of months, and then I changed to capecitabine. And I've been on that for, I want to say, about a year. After a year that I started treatment, I was no evidence of disease, and it's been that way since. And coming up at the 2-year mark, recently had a discussion with my oncologist as to whether I want to stop the capecitabine or not, which I don't have an answer to that actually, because I don't know, and I'm hesitant to change anything. Because if I were to remove the capecitabine and I were to have a recurrence, I'm not sure how I feel about that. And then I actually I emailed you regarding the immunotherapy. I don't know whether it's typically something that is continue long term, or I don't want to stop all treatment altogether, right? So I do want to stay in some sort of maintenance treatment for I think for psychological reasons probably. And yeah, I mean basically that's the question regarding like how to handle this in the long term. I'm not sure, because it seems that every um, oncologist does it differently as far as whether to continue treatment, continue immunotherapy or stop it or whatnot. So um, I'm not sure what it's going to be my situation.
Yeah, I think it's shared decision making for every patient, but Just for everybody on the call, most of our trials, the data goes out to about 2 years. So people continued like the trastuzumab for 2 years in Keynote-811. A lot of our immunotherapy trials stopped to 2 years. So like if you're a purist, we don't really have data beyond 2 years, and you could make a good argument to stop. But I think more common in real world practice, I'm with Elena, which is, you know, don't rock the boat if things are working. Um, and I think a lot of people share your perception, Frank, that, you know, if something happened, you'd always be asking yourself if it was because you stopped, even though we don't know if that would be the case. Sometimes I will do like circulating tumor DNA around the 2 year mark. And if it's like completely negative where it was positive before, I might feel a little more comfortable with stopping. But this is sort of like treating myself more than anything else. Um, it's a great question. It comes up a lot in clinic, and thanks to some of our new drugs, it's comes up more because we have patients living longer, which is fantastic. Few questions from the Q&A. I'll handle the one from Karen really quick, which is Clarity Gastric O2, which is the Claudin antibody drug conjugate in combination with chemotherapy and immunotherapy, is actually already open. It may not be open, I don't know where you're from in the world, but it is an open phase 3 trial. Okay, let's go with this one for you, Elena. CAR T in Claudin positive, and then we'll maybe bring it back to some of the ASCO updates but Claudin's another target, so.
I love that you asked me about CAR T because I actually am trained to treat patients with CAR T, although I'm giving it up to our younger faculty. But just before, Frank, if I can just go back for a second to your question, because your situation sounds like it's a little bit different. Yeah, actually, in Canada, our patients can only get IO in the HER2 negative setting for 2 years, and then we have to stop. We actually have no choice but to stop. That is what the government funds. The only way patients can continue is if they have private insurance. And even then, private insurances will often, as Sam has kind of indicated, because our trials don't go beyond 2 years, will require us to stop. So I don't think there's a right or wrong answer to your question, to be 100% fair and honest. And in Canada, we actually have to stop at 2 years. We have no choice in the HER2 negative setting. HER2 positive is a little bit different because of how the trials were done, as Sam alluded to. In terms of CAR T, I do think it's an option. But as Sam knows, CAR T therapy is interesting. And I think there's some promising studies out of Asia. Unfortunately, we don't have as much data in the Western population. I will be honest and say that I do have a belief, and I think there are more, for me, of more interest are, for example, Claudin ADCs, or potentially bispecifics, which might come into play as well. I think CAR T is something that I would potentially consider in very fit patients. But you have to remember that CAR T therapy, number one, it takes forever to make these cells, quite a while. So the patients have to be stable while you're making this type of therapy. So you're selecting a very small group of patients. I think the secondary issues are obviously there's a certain amount of toxicity which you experience with these treatments. I love your cat, Sam. I just saw your cat's tail come through. And then I think that's something to be taken. It's a Bengal to be taken into consideration. So I love cats, by the way. So I think that's the second thing to be taken into consideration is number one, if you're considering these trials, are they the right trials for you? I think there are other Claudin agents, which to me are less toxic and do definitely show promise. And remember, a lot of the trials that have been published so far are out of Asia, and we don't really know how they would apply to our patients. Sam, I'm curious to hear what you think about CAR T and solid tumors in general, because where it's been shown to work really well is obviously liquid tumors.
Yeah, I think I'll take one of the other questions from the QA too, which just backs up a tiny bit, which is what is CAR T? CAR T is basically where we do something called pheresis, and we take your immune cells out of you, take them to a lab, basically force them to overexpress a receptor against something we know the tumor has. So it might be Claudin, could be HER2, could be TROP2, could be basically anything. but you want a target that's pretty specific to the tumor and not the normal person because you don't want to have a whole army of immune cells attacking your normal body. And then, as Elena said, we basically wait a bunch of time to make that happen, and then we give you back a crap load of immune cells, and people can get really, really sick in the hospital. There have been deaths from, these types of immune reactions, but they're also the kind of stories you read about sometimes where someone has a one single treatment and their cancer is gone. That can happen. I think it's quite uncommon for solid tumors, and the Claudin CAR T, I think proof of principle that it can work, but I'm not convinced that the juice is kind of worth the squeeze yet because the durability is not so great um, from the current generations. I think that will get better, um, but we're not quite there yet. All right, I'm going to bring it back to the perioperative world because there's a couple questions in here. And maybe you can talk a little bit about your thoughts on the Astrum trial from ASCO that Yelena mentioned. But there's a question that says, people who are early stage and got FLOT and durvalumab, what is the guidance about how long you should do durvalumab after surgery? And maybe talk a little bit back up and talk about the perioperative trials.
Yeah, you know what? I really think that's a great question. And it's a question we actually got asked in Canada a lot because for us, until 2 days ago, we actually did not have durvalumab covered. So a lot of our patients had to decide whether they wanted to pay. And then, as I think a lot of you know, the cost of these drugs is about $12,000 per treatment. And so then you would be looking at a treatment that's about a year. So that's over $100,000, which is a lot of money for many patients. So this was actually, I actually got a lot of these questions, Sam, from my patients. When should I stop? Is it enough to have the 2 months of, so let's just talk a bit about the trials, because I think Sam is right. So our first, if we go back too far, and I'm not going to go back too far, I'm just going to talk about FLOT. So FLOT AIO looked at FLOT compared to our old standard of care, which was ECF or X. And that's how we found out that FLOT was better than ECF or X. It improved survival over our old type of chemotherapy. Matterhorn is the newest study, which looked at the addition of durvalumab to FLOT. Interestingly, all patients seem to benefit regardless of PD-L1 status. But I think patients that are PD-L1 positive do benefit more. In terms of what the absolute benefit is, at 3 years, there is a 6% absolute survival benefit. It means that we would cure 6 patients out of 100 that would not be cured otherwise. The way the study was done was that FLOT and Durva were given for 2 months before surgery. Patients had surgery, then 2 months of FLOT Durva post-surgery, and then they would finish up to a year of Durva. I think the most common question, and I don't know if this is the issue with Sam as well, that I get is, do I need to finish that year of Durva, for example? The answer is we don't know. I think generally what we have seen in previous studies that the most important therapy that we give is perioperative therapy. What I will also say is that for me, looking at this study from China, even though it doesn't exactly apply to our patients because we generally give triplets in fit patients, it does reassure me that probably the most important part of the treatment is still that perioperative portion of treatment. I kind of hope that we will be able to look at some de-escalation, Sam, in the future, to be 100% honest, because I myself am not sure if we need to give a year of therapy to all patients. But right now, I'm not sure how to answer that question. Do you have a better answer than me?
Yeah, I share the same question. So I think in the curative setting, when of course the goal is cure, it's hard to deviate from the phase 3 trial data and say like maybe you don't need all 10 more months of durvalumab, but until we know that, like we're not gonna shortchange in case there's benefit. Someday, I think other tools, cell-free DNA, et cetera, might help, refine the patient populations who benefit the most from these things. But now, you start on the pathway and you finish the pathway. Um, that's what the evidence we have supports. It's not an easy pathway. FLOT is hard, but unfortunately, that's currently our price for the cure, at least a try for the cure. Um, Maybe, what do you think that we will be able to go down to doublet chemotherapy, or in this trial, which obviously selected people who are PD-L1 high?
Yeah. So I do like, I mean, I think my dream and probably your dream is that we start looking at biomarker driven subgroups of patients. I mean, for years, for multiple years, we've taken all patients, regardless of the molecular makeup of their tumor, and treated them in exactly the same way. To be honest, I'm not sure that's the right way to approach this disease. We now know there are different subgroups, right? There's mismatch repair deficient tumors. We know that. We know that they might benefit from IO alone, for example. Probably they don't need chemo. We know that there are HER2 positive tumors. There are better HER2 directed therapies. Would they benefit from getting these better HER2 directed therapies? Claudin positive patients, would they benefit from getting Claudin? And I think, where the future is going, at least I hope, is treating patients based on the biomarkers they have. So more personalized approach. That's kind of the dream. And there is a study which is being done by the AACR, which is in the process of activating in some centers in the US, yours being one of them, and mine being the one in Canada. So let's hope that that's the way we're eventually heading. I think in terms of doublets, Sam, I personally think that doublets, FOLFOX is probably the most important portion of FLOT. And I think you and I probably will agree on that, but I do want to hear your opinion on that. That being said, off trial, I do give triplets, FLOT, but I do wonder whether replacing that D or taxane with a biomarker-directed therapy may be less toxic and maybe better for patients.
Yeah, it's a good question to ask, and I think that's why we do trials. And I wouldn't be surprised if some of those biomarker groups come out on top in the long run. Frank, I'm going to come back to you, and then I'm going to address your question in the Q&A. But maybe since we're talking about toxicity from chemotherapy, FLOT, FOLFOX, what was your experience like when you started in the beginning with, doublet chemotherapy?
I started with with FOLFOX, and like I mentioned, oxaliplatin was stopped after 6 months because I started having a lot of neuropathy, and the neuropathy was lasting longer and longer. Whereas at the beginning, maybe I'll have neuropathy for a few days. Later on, it would linger for maybe 2 weeks. Once I changed to, now that I'm on capecitabine, one of the issues that I was having with it was the hand and foot syndrome, which I guess is pretty common. And after a few dosage reductions, now it's fairly manageable with urea creams, and basically I've become very high maintenance, so I'm always wearing either socks with the creams or putting creams on at night, and I have to wear these creams and sleep with gloves on at night, which is very weird at first. And funny enough, I have some white gloves, and my wife says that I look like a mime when I'm going to sleep. So, but the toxicity, at least in my case, I'm not sure whether I've been lucky or not. But they've been tolerable for the most part.
Hopefully you can get out of the box when you wake up.
Yeah.
Do you have any lingering neuropathy, anything, or it completely went away?
No, it completely went away. I think if I do, it's very mild after I stop oxaliplatin.
Yeah, that's great. I think as oncologists, I think Elena and I would also, we try to be attentive to patients and ask them about this, but every once in a while, people are left with some form of permanent, decreased sensation, etc. Elena, I'm going to come to you with this question, which is a fair one, which is for people who have claudin positive tumors, and let's say their first line is starting to fade, like they're on 5-FU and Nivo, but you now know they're claudin positive. Would you add on the Zolbi or call this, we don't have data in that specific scenario. Probably second line is more typical.
Appropriate. So you know what? In Canada, this is a really tough setting, to be honest with you, because there is no way to get Zolbi in the second line setting, Sam, for us. I think, as you and I know, there is data that supports potentially adding in PD-L1 positive patients both the drugs together. And that was presented by Kohei Shitara at GI ASCO. However, that is not available currently. So if you have not started treatment and you're PD-L1 positive and you're claudin positive, I think the best bet is to go on a clinical trial if you're well enough and able to travel to a center that has the trial open. Off trial, I will be honest, in Canada, if patients are experiencing toxicity, let's say to Nivo, and they're claudin positive, we have switched them to the claudin agent and stopped Nivo, or vice versa. They started Zolbi, we switched them to Nivo. But the only reason we can switch currently is for toxicity and not for progression. If patients progress, to be 100% honest, my preference would have been to consider a trial. So we've had the Clarity Gastric 01 study, which was with the claudin ADC agent, which will hopefully read out fairly soon. So there might be evidence for claudin therapy in second or later line in claudin positive patients. What do you guys do in the US? I'm curious because I do know it's available differently in the US than in Canada.
Yeah, I think I have done the right from the get-go, like Folfox, Zolbi, and PD-1 sort of based on Illustro data, and that's mostly because we can, even though it's not an approved regimen, and there's a phase 3 that is accrued, and so we'll have the answer at some point. But I have not sort of added Zolbi at 6 months into frontline therapy. I'm also just not sure that that's really going to be something that's going to salvage that clinical situation if someone is starting to progress. Sometimes we just have to recognize progression is progression and time to move on to the next line. But everybody's a little different. Sometimes if a pattern is like one little spot that popped up, we might even think about other stuff, like if it's radiation for some patients periodically. But let's bring it back to a topic that comes up a lot. Wasn't really addressed at ASCO this year, but it is something that comes up in all of these webinars and all of these advocacy groups that are here, collaborating today. Probably is top 3 of the things on their list, which is peritoneal disease. And there's a question from Cecile, which is about so-called bidirectional therapy, intravenous chemo with intraperitoneal chemotherapy. So not HIPEC, but serial IP chemo for those listening. Obviously, this is something that we haven't been able to kind of prove on a global scale reliably, but maybe sort of, are there people, Elena, that you think about this for, that you see as opinions for? And then I don't know if you guys have this stopgap trial, but I can comment on it after.
No, yeah, I want you to comment on the trial. What I recommend to patients, Sam, 100%, is I have this very same discussion. I don't think we've been able to prove the benefit of this. If this is something that you're interested in, I think the best way to do so is to participate in a clinical trial. I personally find it very difficult to recommend something that has not been proven to prolong survival in our patient population. I will say that in Ontario, HIPEC has recently been funded for patients with gastric cancer, which is quite surprising, and I can see that you're very surprised, because as you well know that we don't really have strong data to support the use of HIPEC. However, patients that are candidates for HIPEC in Ontario are extremely selected. So we're talking about extremely low PCIs or cytology only positive disease, and only after at least 6 months of systemic therapy. But but my opinion on it, because this actually gets asked of me a lot of times, it is systemic treatment that has been shown to prolong survival. Stopping such systemic treatment can be, in my opinion, especially if that treatment is working, also a risky proposition. And I think if you're going to do something like that, I think it's best done on a trial. Sam, what are your thoughts?
Yeah, I totally agree. I think this is something the whole gastric cancer community world needs to tackle, and it needs to be done in like structured ways, like trials. Clearly, I do believe there are patients who benefit from these approaches, and we all have those patients where they got high PEC in a situation where they had a very high recurrence risk, and then their cancer just didn't come back, or they got an aggressive surgery and it didn't come back. The problem is picking them, and doing it in a reproducible way is something we just can't really do quite yet. The stopgap trial is built from a very, very lovely surgeon in UC Irvine whose own lab and work has laid the foundation for this. But essentially, people who haven't progressed after a few months of standard first-line chemotherapy get, laparoscopy, and then they can get intravenous chemotherapy with intraperitoneal Taxol, and then they do that for a few months, and then they get another laparoscopy. And some of those patients are taken to surgery if they've had, good enough response in the peritoneum. So it's an organized, structured way of trying to address the question of, is giving intraperitoneal chemo adding on top of our systemic chemo, and allowing for real biomarker-directed chemo. So sort of like the ideal situation to test, in my opinion. And hopefully the trial will be positive. I think it would be wonderful if we can establish that this helps people with peritoneal disease. A lot of our patients don't have disease only in the peritoneum, so we're stuck dealing with liver and bone and lymph nodes, etc. So it's clearly a selected group of people. I want to come back, and maybe Frank, I'll ask you to start this theme off about sort of emerging biomarkers and new stuff, coming back to the savolitinib data from ASCO. Frank, in any time during your treatment, do you know if your tumor was tested for other stuff beyond like HER2 or Claudin or PD-L1? Did they ever talk about, sequencing the tumor, or did you ever get one of these ctDNA tests to look for other mutations?
Yeah, at the beginning, I did a few. Well, I think one of them was foundation medicine. The other one was I don't remember the other tests that were done, but I think they were looking for any um, therapeutic options that I could have later on after the first line. Also for any clinical trials that may be opening up in the future.
Yeah, that's great. I think maybe Elena, just talk broadly about sort of what's the practice in Canada and sort of sequencing world.
So unfortunately for gastroesophageal cancers, NGS is not covered. So we do definitely discuss it, Sam, and we're lucky at Princess Margaret because we do have a pathway through a study to get NGS done for free for our patients. Otherwise, patients would have to pay roughly $6,000 for NGS is the price in Canada. And it's not covered by most insurance. However, we do recommend it for patients who are able to afford it. Although, to be 100% honest, I don't push patients who can't afford it either, because as you know, the chances of finding targetable mutations in gastroesophageal cancer, because this is not a disease of mutations, it's more a disease of amplifications, is not superbly high. So if I can get it done, but I certainly I don't recommend that patients sell things to do the NGS test. I'll
Yes.
be very honest with that.
I've used that analogy as well. And we have a little more access to it, and it's often covered. So, when it may not guide our decision for the initial choice of treatment, like you said, but we do use it, as Frank referenced, to sometimes explore like next things. Speaking of amplifications and one of the groups that we know about, but we hadn't had data, what was sort of your impression of that MET amplified trial? I mean, impressive that they got it done in the first place. Um, but, for a monotherapy drug, not so bad.
I totally agree with you. And I think to be 100% honest, I'm even more excited because, as you know, there are CMET ADCs now. And I think that's where that bystander effect may make a difference, even in patients with low level, amplification, which is a little bit more common, right? So, to be honest, number one, kudos to them for doing the trial. It does benefit some patients, and I hope we're going to see more trials in that setting. I think there already are some phase 3 studies with CMET ongoing.
Yeah, I agree. So for everybody else, it's like basically about 5% of stomach and esophagus patients will have MET amplification. And this is the first well, not the first, but the largest trial with an active drug that worked. I mean, we had those old naked antibodies that didn't seem to do much. Um, but better drugs, better patient selection, it's a pretty good recipe to get to success. I'm dropping a cooking reference for Hans, who's on the panel. Um, all right, let's get back to actually staying with the ctDNA kind of theme. There's a question from anonymous attendee asking about using Signatera for treatment decisions or for monitoring. So let's say it was fully accessible to you at no cost in Canada. Would you use it in perioperative setting? Would you use it in metastatic disease, or would you say it's nice data, we can talk about it?
I would say it's nice data. It's not yet validated in this disease. I think we're all excited about using it as potentially to detect MRD. MRD means minimal residual disease. And what we mean when we say MRD is we see the ctDNA be positive, but we don't see evidence of metastatic disease on CT scans because then it's too late to intervene. What I mean by intervene is we hope that if we can detect MRD or minimal residual disease, we can give the patient a drug that can potentially clear the ctDNA. I think that's the dream, Sam. But I don't think that ctDNA is validated. Sometimes I feel like it gives patients more anxiety. Patients do pay for it in Canada, but I really don't know how to change my treatment. If I'm giving them flawed durva, and then I'm giving them flawed durva after treatment, how do I escalate the treatment if their ctDNA is positive? Right? And I think that's what becomes really difficult. And I think that's where we are, at least in Canada. I don't know how you feel about in the United States.
Yeah, I mean, we're obviously all looking at the same data, so I think we have the same opinion that it's a very cool tool, and I think it's going to be part of the future. But right now, it can sort of reinforce your thinking. Like you're like, oh, I think this patient's going to do well after they had a path CR. And if their ctDNA is also negative, you probably feel even better.
Yeah.
Um, but and same thing goes for if it's positive, you're going to worry because you know that those patients have a high risk of their cancer coming back. But exactly like you said, I don't really have anything to add. Like, we don't have any evidence that we can do anything about that quite yet.
Yeah, so actually this question was from me, Sam. It was more, I think from a in the metastatic setting of if a patient is no evidence of disease and they've been using the Signatera as monitoring and it's negative for some time and then it comes positive, right? At that point, it's just a waiting game until it shows up on scans.
It's a very common and stressful, anxiety-provoking scenario that honestly, I look at the value because sometimes the value is right at the very limit of detection. And the first thing I will do is repeat the test, like, a month later to see if it's actually going up or if it was just an isolated spurious value around the low end of the range. You don't have to remember any of this, but this is just sort of what we think about. Um, if it is rising, if you have two data points in a row that it's rising, then it is likely that at some point, But some point could be 6 months from now, could be a year from now, you would develop a recurrent disease. That's sort of what the literature suggests. But um, my first step would be usually to repeat it. I don't know what you would generally do if it was all available to you, Elena.
I mean, we do this for trials. We see it be positive and then negative on the next test. I think that's what you're alluding to, Sam, as well. Um, I think the answer right now is the same thing that you do. We don't, it's hard to know exactly, Frank, what to do with these tests right now. What I hope, and I think what Sam hopes, is that we're going to do some trials that will help us answer these questions. But right now, I think the answer is we really aren't sure. And there is some data, for example, in breast, that does look promising. So let's hope we're going to do this in gastroesophageal soon.
Yeah, totally agree. Some of these tumor types that are just that much more common, they sort of start to test these things even a little sooner. Although now I think gastric is right on the front line with everybody else, which is great. Um, I don't even know the answer to this question, but it's in the Q&A. I've never used ralatrexate in my life. I know what it is from reading, but I've never used it. So, what about replacing ralatrexate for 5-FU in someone who's on immunotherapy? Like, would you have any concerns about this?
So I've used it. So you've never used it.
No, I don't even think it exists in the US, really.
So do you know why we use it? So if someone has encephalopathy to 5-FU, for example, which I've had twice in my career so far, I feel like I attract, me and my patients, our combination sometimes, I don't know if, it's unusual things. So encephalopathy, for example, can happen. There's also, rarely you can have coronary artery vasospasm, in which case we would replace raltetrexate for 5-FU. So both of those situations I have. The data for raltetrexate comes primarily from colorectal cancer, as Sam knows and I know. However, I have used it and I've used it safely, but I don't think any such significant data exists. But that being said, if 5-FU, which is the backbone of what we use, is not able to be used in a patient, I think raltetrexate is a reasonable option.
That would be my answer too from reading, but I have no personal experience. All right, we're down to the last like 3 minutes before the closing remarks. So if you have any final questions, feel free to put them in the Q&A, but maybe I will bring it back to the ASCO updates for the final thoughts. We talked about the savolitinib, we talked about the periop and Matterhorn a bit. We obviously talked about Zani. What is your sort of thinking around dual immune checkpoint blockade? So we've seen TIGIT stories. Now we had Ipi-Nivo FOLFOX in Attraction 6. I mean, do you still have some enthusiasm for some of the bispecific strategies to target, dual checkpoints?
I mean, obviously the TIGIT story was very disappointing. And as you know, there are bispecifics looking at PD-1 TIGIT. I will be honest, I guess the success with Zani gives me hope because I do think bispecifics work in a different way. And just as Yelena did say, the CTLA-4 PD-L1 data does look promising in lung cancer. And what's old is new again. PD-L1 VEGF also looks promising in lung cancer and is also being tested in gastroesophageal cancer, Sam, as you know. So I kind of do have new hope for bispecifics. I don't think we should stop studying it regardless, right? We made this step forward in HER2 positive disease. I guess my hope is that potentially this would be beneficial to patients. What I think about dual checkpoint blockade, probably my personal opinion is that it will benefit patients with high PD-L1 CPSs most. And then also, I don't think PD-L1 is a good biomarker for immunotherapy. So my hope is also that we might come up with a better biomarker in the next, 5-10 years that will tell us who will benefit the most from these drugs.
Yeah, I agree. I think the individual component, PD-1 TIGIT, individual component, Ipi-Nivo, has not worked out. PD-1 LAG-3 not worked out so well for gastric. But the bispecific format does offer some theoretical advantages. So I hope so. I think we'll need to see the data. The catanilimab trial was, of course, compared against chemo alone. So a little bit harder to make the comparison against chemo plus Nivo, for example. Someone asked, oh, these are good ones. I'll give you this question because then we really got to get to closing. But what do you do for people that has no biomarkers, Elena?
So, Sam, I think my preference is I still put them on trials. There are trials for unselected patient populations, and I think the best bet is still to look for new biomarkers and new drugs for these patients if they're able to go on trials. I think off trial, the truth is if someone doesn't have any biomarkers, if they're PD-L1 negative, I would give them, and they can't go on a trial, then it's chemo alone. And I think it's similar in the US. I think you guys do the same, CPS negative. No biomarkers whatsoever. That being said, I think there are some unselected trials which look promising. And if a patient is strong enough, my preference would still be to put them on a trial.
Yeah, me too. Me too. It's thankfully an increasingly smaller group of patients as we have more biomarker-directed therapies, and someday hopefully it will be nobody who doesn't have a biomarker, but right now it definitely happens, and that's what we do too. Sorry to the people who couldn't get their questions answered. There was a flurry in the last minute. Want to thank Elena and Frank, and also, recognize and thank all the advocacy groups that came together to make this webinar possible. You guys touch, I think, a huge proportion of patients with stomach cancer around the world. So big collaboration between all the providers, the caregivers, and the groups. And then I will turn it back to the team to close us out.
So I just wanted to say thank you to Dr. Janjigian for her review of ASCO, and also to Dr. Klempner and Dr. Elimova for taking the time out of their incredibly busy schedules and take this hour to answer all of your questions. And as well to Frank for giving us such an important insight, which is the patient insight, and telling us about his experience. So this was the first of a collaboration webinar for updates from some of these huge medical conferences, and we were really happy to do this as a separate organizations came together to put this together. And so thank you to Debbie's Dream Foundation, the Gastric Cancer Foundation, GI Cancers Alliance, Hope for Stomach Cancer, My Gut Feeling, No Stomach for Cancer, and Stomach Cancer UK. If you have any questions, you can always direct them to any one of the advocacy groups that you belong to, or anyone else. Please do look for hopefully our next collaboration, which will be a webinar following ESMO GI, and that will most likely happen sometime in July. And of course, if you have any other questions that are support or advocacy related, please reach out to any one of the advocacy leaders teams that are here. And thank you to all of the people that joined us this past hour. It was so informative. And so we hope you have a great night. And once again, thank you to everyone.